So today our topic is on the Brugada syndrome. So what do you understand by the Brugada syndrome? So Brugada syndrome, this is usually genetically transmitted. It has got an autosomal dominant as an autosomal dominant syndrome. So I'll just show you one ECG of Brugada syndrome before going into the details. So look at this thing. Look at the CCG. So can you see this ST segment? Okay, so there is an elevation of the ST segment. Okay, so if you do remember from a normal ECG, I show you a normal ECG. Look at the normal ST segment here. Yes, this is a normal ST segment. You can see. Okay, and the one which I showed you, that was the elevated ST segment. So you can see ST elevated segment can also occur in pericarditis. It can also occur in myocardial infarction. So yes, it can also occur in those conditions also. But here just a minute, it has got a covert shaped. Okay, so look at this SP segment elevation. Okay, so in this Brugada syndrome, these patients, they have got an SP segment elevation, but this is covert, COVED, covert shaped ST segment elevation. Okay, and this ST segment elevation is mainly found in the precordial, right precordial leads. Which are the right leads? If you do remember, V1, V2, V3. Okay, so mainly in the right precordial leads. And this is followed by an inverted T wave. Can you see this T wave is inverted? So there is a covert shaped ST segment elevation followed by an inverted T wave. Okay, and this is along with this you can also find a complete or an incomplete right bundle branch block. In the previous lecture I had told you how will you diagnose a right bundle branch block, the rabbit ear appearance of in the V1. So along with this you can find a right bundle branch block. Okay, or and these patients, they are susceptible to ventricular tachyarrhythmias, mainly the polymorphic ventricular tachyarrhythmias, and there can also occur sudden cardiac death. It can occur. They are susceptible to that. It will not that it will occur, but these patients are susceptible to sudden cardiac death. Or in these patients, due to these tachyarrhythmias, due to these ventricular tachyarrhythmias, it can also occur during sleep, okay, or at rest, and there can be syncope. And this patients, it's a genetically transmitted autosomal dominant syndrome, and these patients, they usually present, okay, so with the symptoms in the third or the fourth decade of their life. So you can say the similar ECG patterns you can also find out in the anterior myocardial wall infarction, acute pericarditis, or in hypercalcemia, hyperkalemia, tricyclic antidepressant overdose. So you have to differentiate them from the rest of the conditions. So what is the treatment in these patients? Since it's genetically transmitted, so usually we implant a cardioverter defibrillator. So implantable, we implant a defibrillator in these patients, at least those patients who have at least one attack of cardiac arrest. So as I told you, these patients are very much susceptible to develop sudden cardiac death, sudden cardiac arrest. So if this patient has developed a cardiac arrest and after that you came to know, yes, this patient had this Brugada syndrome. So what we do is that we implant implant a defibrillator. Okay, that is called as your implantable cardioverter defibrillator, because we never know this person, anytime they can precipitate with ventricular tachycardia. Okay, so if due to any reason you are not able to implant this cardioverter defibrillator, then you can use quinidine. Okay, so quinidine can be used. Okay, so if you are not able to implant this cardioverter defibrillator in the person. Okay, so this is all about Brugada syndrome. Next, we shall talk about the Commotio Cordis. This is a term which you might have heard. Commotio Cordis. Commotio Cordis, this what happens is that the patient is a normal patient. Okay, so mainly it occurs in children or in young adolescents, adolescents, young adults. Sometimes what happens is that just there is a blow, matlab due to some reason. Okay, so there is a blunt, the unintentional blow to the chest. Suppose the child, while the child is playing, or adolescents, okay, so just like that, okay, maybe they are playing or maybe they are fighting, okay, so due to some reason, if there is a blow on the chest, okay, on the chest, without damage to the ribs, sternum, or heart. So you might feel that it was nothing has happened. You might feel, okay, just it was a normal blow on the, blunt, non-penetrating, unintentional blow to the chest. But due to this unintentional blow to the chest, there can be suddenly, so there will be the occurrence, so of ventricular fibrillation and sudden death. Okay. Maybe afterwards you find out that nothing has happened, there is no damage to the ribs. Okay, the ribs are intact, the sternum is fine. Okay, so there is no other damage to the heart, but suddenly because of this blunt trauma to the chest, there has occurred ventricular fibrillation and there has been sudden death. Okay, so this is the meaning of the word Commotio Cordis, right? So next a term which we come across, that is just sudden cardiac death. So I shall tell you briefly about sudden cardiac death. So what is sudden cardiac death? Sudden cardiac death, from the name only you can understand. Remember, 85% of the sudden cardiac deaths mainly occur due to the ventricular arrhythmias. Okay, so either, a ventricular tachycardia or a ventricular fibrillation. Okay, so these are the 85% causes of the sudden cardiac death is because of the ventricular arrhythmias. So what is sudden cardiac death? Sudden cardiac death is unexpected. Okay, so you are not at all expecting it. Okay, so unexpected. It is non-traumatic. Here there was a trauma, blunt trauma in Commotio Cordis. Okay, so but in sudden cardiac death, it is non-traumatic. And usually it is presumed to be of cardiac causes occurring within a very short period of time, just 1 hour within the onset, within 1 hour. Therefore, the word sudden is used. Okay, so whatever symptoms the person is having, if the person dies, okay, so within 1 hour of the onset of symptoms, in a person whom you know, whether in known or unknown cardiac causes, okay, so in whom no previously diagnosed fatal condition was present, so unexpected non-traumatic death which occurs within 1 hour of the onset of symptoms, mainly due to the cardiac causes, presumed to be to the cardiac causes, that is called as the sudden cardiac death. But the most important cause of sudden cardiac death, 85% of the sudden cardiac death occurs due to the ventricular arrhythmias. It can be ventricular tachycardia, it can be ventricular fibrillation. Okay, so what other causes can be, what can be the causes of ventricular tachycardia or ventricular fibrillation? So the most common causes are your coronary artery disease, okay, ischemic heart disease, ischemic cardiomyopathy. It can also be non-ischemic cardiomyopathy, not necessarily always ischemic, non-ischemic cardiomyopathy. It can be hypertrophic cardiomyopathy. All the, how much you can remember, all the heart conditions which you can remember, aortic dissection. Okay, and some other drugs also like cocaine, or there can be some valvular heart diseases, congenital heart diseases. Okay, so all types of heart diseases, long QT syndrome, Brugada syndrome. Just now we saw in Brugada syndrome, there can be sudden cardiac death, Wolff-Parkinson-White syndrome, certain electrolyte abnormalities, sarcoidosis, amyloidosis, cardiac tumors. Okay, so these are the different causes, okay, so which can lead to the sudden cardiac death. Okay, so what is the treatment? How can you treat a patient who has, how can you prevent? In this, mainly you have to prevent. Okay, so in this, after the person, no one says treatment of sudden cardiac death means you have to mainly think about the prevention. Okay, so prevention. So there is two types of prevention. Okay, so one which is called as primary prevention and secondary prevention. Okay, so primary prevention means in those patients, as I told you, the different conditions, coronary artery disease, ischemic heart disease, Brugada syndrome. Okay, so and long QT interval and valvular heart diseases. So those patients who have got the high risk conditions, you prevent SCD in those patients. Okay, as I told you, whatever condition the patient is having, so you give the appropriate treatment to the patient and prevent the patients in whom high risk conditions is present. And what is secondary prevention? Secondary prevention means the person already, has revived, he was almost he has revived a sudden cardiac death. Okay, so he has revived maybe by giving CPR. Okay, so the person has revived from the sudden cardiac death. Then what treatment you're going to give to the patient for preventing, again, a second episode of such type of thing? Okay, so it has been found, the normal antiarrhythmic drugs, traditional antiarrhythmic drugs like amiodarone, lidocaine, they're not at all effective. They're ineffective in preventing and reducing the sudden cardiac death, and therefore they are not recommended. So rather, what we can give is that we can give certain drugs. Okay, so we can give not the antiarrhythmic drugs, but we can give these beta blockers. Okay, so mainly the cardioselective ones. You can give like metoprolol, bisoprolol, or you can give ACE inhibitors, so or you can give ARBs, so or you can give the mineralocorticoid receptor antagonists. Which what are the names of mineralocorticoid receptor antagonists? Spironolactone, eplerenone. Okay, so they are recommended in patients if the patient has a history of a heart failure and if the ejection fraction is less than 40%. We'll discuss about heart failure in details in another lecture. So in these patients, these are the drugs, okay, so which you can give to prevent. Okay, and in patients who have sustained arrhythmias, okay, so or who have survived, SCD, sudden cardiac death. Okay, so such type of patients, they should be evaluated. Okay, so why it had occurred. Okay, so is there any ischemic heart disease? Okay, and accordingly they should be revascularized. And what is the primary treatment modality in most of the patients who have survived SCD? A patient has survived the SCD, most of the patients we implant, as I told you, in Brugada syndrome. Okay, so implant a cardioverter defibrillator. So this is the mainstay in most of the patients. Why to take risk? We implant a defibrillator. Okay, implantable cardioverter defibrillator is the primary modality in most of the patients. And if the patients, in uncommon conditions, like as I told you, WPW syndrome or any AV bypass tracts, okay, bundle branch block associated ventricular tachycardia, in those cases, we usually go for the radio frequency ablation. If there is any bypass tracts, okay, uncommon conditions, we go for the radio frequency ablation of the bypass tracts. Okay, so this is the main treatment. Okay, so preventing, and if the person has survived, okay, so what are you going to, the mainstay in the patients who have already survived SCD, or you are finding it a high risk, Brugada syndrome, or these kind of patients, we usually go for an implantable cardioverter defibrillator. So this was all about this thing about the sudden cardiac death. So here today we discussed about sudden cardiac death, we discussed about Brugada syndrome, and we discussed about the Commotio Cordis. This is all for today.